After the excellent talks this morning, we are going to move to margin evaluation of breast conserving therapy specimens. Dr. Helal gave a very good overview of CAP guidelines for pathology reporting of breast lesions, both in situ and invasive carcinoma. And one of the question and the controversial point was definition of the margin. And given in this meeting, we did not have a good agreement. One of our colleagues was saying that it was 5 millimeters, and Dr. Halal was saying it's 1 centimeter. So I will try to address some of those issues. In terms of breast conserving therapy, now we have large prospective trials which demonstrated equivalent survival rates after breast conserving therapy and total mastectomy. And for early breast stage breast cancer, now it is the preferred treatment is breast conserving therapy, which is called segmental mastectomy, lumpectomy. They are actually pretty much the same procedure. When patients have breast conserving therapy, they have a lifelong risk for local recurrence. That is the main concern that we have, local recurrence. A meta-analysis of 21 retrospective studies show that the influence of margin width on local recurrence, close to 15,000 patients, that odds ratio for local recurrence for all segmental resections is around 2.4. Meaning that if you have a positive margin or close margin, your chance of local recurrence is almost twice as high. So presence of tumor at margin associated with increased local recurrence. So complete excision of tumor is necessary to achieve satisfactory local tumor control. And we know that both for invasive carcinoma and for great majority of in situ carcinoma, when surgeons perform segmental resection, patients will receive radiation therapy. So this is despite radiation therapy, if we have a positive or very close margin, it is associated with increased local recurrence. And the breast surgeons, when they are doing segmental resection, they need to balance risk of local recurrence and cosmesis. And obviously on this, the patient selection is very important. The size of the breast and size of the resection are two important components. Patients with positive margins are more likely to have residual disease at or near the primary site than those patients who have negative margins. So when we are talking about positive or negative margin and presence of tumor at the margin, the main concern that we have, what is the chance of having residual disease in the patient? So the positive margin does not necessarily mean that the patient has a residual disease. Negative margin similarly does not preclude extensive residual disease. So we really have to make a clinical judgment. And in many scenarios in breast pathology or practice of any other type of pathology in a daily practice, I really do not practice with based on guidelines, based on, this book says this, so we have to do this. We really use our medical judgment. We are all physicians, and our role as breast pathologists is really to guide our clinical colleagues and make a multidisciplinary decision. So if somebody is asking you, as Dr. Halal was mentioning, that they need a perineural invasion reported, why? I mean, where is the evidence? We are in the era that we have to practice evidence-based practice. And if there is an indication for that, and if there is a study for that, I mean, we are all for that, but it really has to have an evidence. So now we definitely have an evidence that positive margin is important. So it is very prudent for, as a breast pathologist, for us to report the margin and pay attention, significant attention, how to evaluate that. So our goal when we are trying to evaluate the margin is not to ensure that there is no residual tumor in the breast, but to identify those patients who are more likely to have large residual tumor burden, therefore require further surgery, which is either re-excision or mastectomy, and to identify those patients who are unlikely to have large residual tumor burden, therefore they are not suitable candidates for breast-conserving therapy without further surgery. So it is not possible to obtain all this information with pathology alone. And today, we really have to practice and make our decisions based on all the disciplines together. So we really need to evaluate the imaging studies. We need to evaluate like the size of the excision, the size of the breast, and then we need to make a multidisciplinary decision. So if you ask me what millimeter that we use to define a negative margin in MD Anderson, I will not give you an answer because there is no single answer for that. For each patient, it is different, and for each patient, we're going to make a different decision. With 2 millimeters close margin for one patient, you may do something different than another patient with the same amount of margin. So we really need to identify if there is a chance that the patient has extensive residual disease, or the patient may have very focal disease and then the patient is going to receive radiation. So it would be okay to have not to have additional surgery. So that's the question. As we know that margin assessment is not a science, we should not really pretend that like when we say it's a 2 millimeter, 1 millimeter, we are giving an assessment. It is not a rocket science that we are not working with. In one section we may say it is a 1 millimeter, and when you do deeper markers, the deeper sections, and it is going to be 0.1 millimeter. We know that. So we should not pretend that, when we say 1 millimeter, it is what it is. So we are giving an assessment, just like radiologists, like when they say the tumor on ultrasound is this much. It's an assessment. So we should really accept that, and we as pathologists, we try to be as precise as possible, but we have to accept that this is not that precise. Handling of specimen is very important, and I'm going to touch on that. There are different evaluation methods, and as Dr. Halal has mentioned, that there is no ideal method. Each method is, it has its advantages and disadvantages, and you have to select based on the specimen, based on the patient, which method is appropriate. Definition and interpretation of margins, either as negative or positive, is controversial. And distribution of tumor in breast is different, and different biology, different tumors have a different distribution. A high-grade invasive carcinoma, single focus of tumor, even if you have a tumor right at the margin, 0.1 millimeter, might be okay. But if you have an extensive micropapillary DCIS, accompanying that, even 1 centimeter margin may not be adequate for that specimen. So you really have to accept that the biology of tumor is also very important. And we know that tumor biology impacts systemic therapy. All specimens should be sent to pathology intact. I know we have our surgery colleague here. This really has to be a major message to all surgeons. We really do not want to receive specimens when they are sectioned. And all specimens should be oriented with markers. And it really is not that important. Is it going to be a suture? It's going to be clips. Whatever works between surgery and pathology is okay. In our institution, we have 20 breast surgeons, we have 11 pathologists. I mean, we do things a little differently. Whatever works for each institution is acceptable, as long as when surgeon says this is superior and it is understood by the pathologist that area is superior. How much of that area is superior? Where does the lateral margin start? Where does the medial margin start? Again, these are very subjective, and I'm going to show you some additional points about this. Again, we really have to have a very open and clear communication with the surgery, because a lot of the times when we say the margin, the superior margin, and when it has become the medial margin, then the surgeon needs to understand where that is exactly. So it is really the job of both surgeons and pathologists to understand exactly which margin we are talking. So the communication between the two disciplines is a lot more important than how we do it. And some institutions, instead of giving superior lateral designations, they give the Clark designations. That's also acceptable. Whatever works is acceptable. Many institutions, including MD Anderson, we use multiple color ink to identify the different margins. And it is an acceptable practice, but it is not required. The whole idea is when you look at the sections, you need to identify margin. So if you ink multiple colors indicating that this is yellow, so this is superficial, this is blue, it is superior, if you examine the specimen, and if you keep the specimen orientation, and if you take your sections even with one ink, that's also acceptable. So the whole idea is to be able to recognize and identify each margin and be able to report it accurately. So whatever works in your hand is acceptable. So just because CAP says and MD Anderson does 6 colors, that everybody has to do 6 colors, no. Especially with your limited resources, you cannot find 5 color ink, and 1 color ink, which is India ink, is the cheapest, and in my opinion it works the best. Even 1 color ink is appropriate, and as long as you keep your specimen oriented. So after we ink the specimen, we serial the section, and then we examine each section very carefully, and when we identify our lesion, we evaluate the margins carefully. The gross inspection is really the most important aspect of margin evaluation. I cannot stress this enough, because in many institutions in the United States, grossing is done either by first-year, second-year residents who really don't have much experience, or by PAs. Some PAs are good, some PAs are not that great. In our case, we, as the pathologist who's signing the case, we go and look at every single segmental resections. To me, residents, fellows can look at the slides, but I really would like to look at the gross myself, because how you are going to section the margin, how you are going to put your sections is a lot more important than looking at slides, because looking at slides, everybody can do it. You can get a consultation, you can do deeper levels, you can do that. But to evaluate the margin correctly, you have only one chance. That is the time of grossing. In terms of precision of painting the breast specimens, as I said, even though 2 margins are indicated indicated as superior lateral or inferior medial. How are we going to say where the inferior or superior margin starts and ends? It is really pretty arbitrary. So in this study, the investigators have looked at experimental models using partially filled water balloons, and they asked different examiners to paint the 6 surfaces. So this is how they ended up. Okay, here is the superior suture, and here is the lateral suture, and they asked the 4 different residents to ink the lateral margin. So here is the first resident in the lateral margin all the way here. And this resident inked the lateral margin here. And this resident inked the lateral margin like this. So really this is not science. So it's very important to recognize that when I say this tumor extends this lateral margin, the tumor is here or the tumor is here. So it really is variable. And how do we get around this? Is there any way that we can get around this? Unfortunately, a lot of the times, breast comes as a lump of adipose tissue, so there isn't really any anatomic landmark. It is not like kidney. When I say upper pole of kidney, all of us can understand where it is. But when I say superior aspect of breast resection, it can be anywhere. So it's really it is not that precise. But at the same time, when we are talking about re-excision, and when we say it is superior margin, the surgeon is not going to go and get this little tissue. Hopefully, he or she is going to go back and get a wide excision from that region. So when people looked at when is the best time to ink the specimen, because there is also some suggestion that maybe the surgeon, when he or she takes this segmental resection, should ink the specimen and send the inked specimen to pathology. And there are some arguments against that. Well, they don't have time, so they are going to ask the nurse who may not know, and there are all these issues. But when it was compared, the later inking by pathologists versus intraoperative inking by surgeon-pathologist team, there was really a difference in terms of positive margin. It was 23 versus 46, and for re-excision rates, 90 versus 38. So the ideal situation is where the surgeon brings the specimen to pathology and then says, here is the superior margin, here is the inferior margin. And I know this is the ideal world, but we will try to do that as much as possible. And when we, after we ink it, we look at it grossly. As I said, the gross inspection is really a very important component. Even for DCIS, we say DCIS is not a palpable lesion, but especially high-grade DCIS, when you section the specimen in a fresh state, you can really identify the high-grade DCIS. So looking at specimen closely when you section it into 4 or 5 millimeter thickness, it's really helpful. And based on the gross inspection findings, we can do frozen section, we can do touch imprints, and we can do specimen x-rays. And again, there is no single best method. All methods are subject to sampling error. And if you look at all methods together, our positive predictive value is 90 to 95%. So if we say a tumor is at the margin, either based on our gross evaluation, based on our frozen section, usually that margin is positive. False positive rates in margin evaluation is extremely low. However, negative predictive value is extremely high. So up to 50% of the time when we say it's negative, and the lesion might be at the margin. And with the invasive lobular carcinoma, with DCIS, this negative predictive value is a lot higher. If the tumor is a well-defined mass, just shown in this cartoon, it's easy. We just measure it grossly. We don't even do a frozen section. So if the tumor is like this, you can identify the tumor very easily, no question about it. The surrounding stroma is very fatty. No, I can say very easily that this is the tumor without a problem, and this is the margin. So even if it is a very close margin, I would feel very comfortable to call this margin negative based on gross inspection, and that will be the end of intraoperative evaluation. In this case, however, here is a dense fibrous area. Here is the skin, and the area of fibrosis blends into the surrounding stroma. Here, I really cannot tell where the tumor ends or starts. It's very difficult. Here is the biopsy, previous biopsy site, so we know that tumor is around here. And this was an invasive lobular carcinoma measuring 6 centimeters. So all this thing was a tumor. But grossly, this would be very difficult. So how do we do intraoperative evaluation of a case like this? Before I look at any specimen grossly, I need to know what the diagnosis is and what the imaging findings were. So I really need to know if this is an invasive cancer or in situ carcinoma. If it's an invasive cancer, what type of cancer it is. If the patient has received any chemo or not prior to excision. And I need to know what type of imaging which was done before the surgery. Nowadays, almost all patients have imaging studies done before they do segmental resection. Great majority of them have ultrasound. So I need to know what the ultrasound finding was, if there was a single nodule, multiple nodules, how big the ultrasound or the tumor was. So without that information, I will not look at any specimen grossly. So in this case, we knew that this was a 3 to 4 centimeter, that's what they reported in ultrasound, mass on the ultrasound, and they described as an ill-defined margins. And it was an invasive lobular carcinoma on a core biopsy. So with that, we said we really cannot tell if the margins are negative or positive grossly. So we had to do frozen section, and we did frozen sections on this. So based on appearance of the specimen and based on patient's previous diagnosis and imaging findings, we can say what type of intraoperative evaluation method that we are going to use. Frozen sections are widely used. False negative rates can be up to 20%. False positive rates are usually quite low. Freezing artifacts hamper the accurate histologic evaluation, but many times we are not trying to classify an intraductal lesion. So if we are doing a frozen section for already established diagnosis of high-grade DCIS, and if I see intraductal epithelial proliferation with a high-grade nuclei, I'm going to recommend additional margin. So we are not trying to make a definitive diagnosis. In intraoperative evaluation, our goal is to recommend additional margin during surgery or not. So a lot of the times this freezing artifact is not that important. One important caution is that if the core biopsy shows a papillary lesions, then I would try not to do frozen section of the lesion. because papillary lesions are very difficult to, first of all, to get a good frozen section. Secondly, they are a lot more difficult to make a diagnosis on frozen section. So if the initial diagnosis on core biopsy is a papillary lesion, I will try to avoid freezing the lesion. The margins can be frozen, but not the lesion. In some institutions in the United States, touch imprints or smears have been used to evaluate margins. They reported that with touch imprints, all surfaces of lumpectomy can be imprinted on the slides, and so you can have on one slide you can have an idea of a large area of the segmental resection. In our institution, we never have implemented this. Again, if you gain an experience with it, and if it works for you, it's wonderful. In our hand, we were never able to do it. And obviously, it does not alter the specimen, so it is a main advantage. And secondly, in many of the instances, our lumpectomy specimens, I found the surfaces quite irregular. So to me, doing a touch imprints of that is not that easy. And in addition to that, in-situ versus invasive tumor cannot be differentiated, but to me it is not a very major contraindication, because even if we say in-situ carcinoma in a margin, re-excision is needed. As I said, in our institution we don't use it, but in literature there's an extensive multiple studies showing a good results. So if it works in your institution, you can use it. In terms of obtaining margins, shave margins or perpendicular margins, again, we don't have a personal preference. We make a decision based on the appearance of the lesion. If a tumor close to a margin like this, doing a margin and fast margin like this, a shave margin, is not a good idea. But if the tumor is really far away from this margin, we would not even do a frozen section. We would just say it's a grossly negative. But if there is a need to do it, then making a shave margin on this margin would be okay. But for the closest margin, we would prefer to have a perpendicular margin where you can see the tumor and the ink margin, so you can make an assessment how far it comes. Because sometimes grossly the tumor is 2-3 millimeters away, but then there is an in-situ component around it, and when you do the frozen section, you see the tumor right at the margin. The downside of perpendicular margin is that it requires too many sections. So that's the reason we do not want to do perpendicular sections all around the lumpectomy specimen, but we do perpendicular margin only where tumor grossly appears to close. So again, this is, I would like to emphasize again that we pay attention, significant attention to gross appearance, how and where we are going to select our frozen section. And if you look at the literature, perpendicular and shave margins, how many times when we use perpendicular or shave margins, we do the re-excisions, and how many times we found the residual disease. There, the reported series show that there is a difference in terms of positivity rate and re-excision rate between the shave and perpendicular margins. But when you look at the important, biologically important parameter, which is what percent of the time we find residual disease in the re-excision, there is no difference. So either shave or perpendicular margin, it can be used, and again, we make a decision based on individual specimens. So just like how you approach the patient clinically, we try to approach each specimen individually, and we use our medical judgment. Intraoperative X-ray assessment of segmental resections, especially for those non-palpable lesions, is very important, and it also directly assesses the large area of the specimen. So when we receive a specimen like this, we do this is a needle localization specimen, as you can see. We X-ray the specimen first. We identify the area of abnormality, which is targeted, and then we serially section it, and then we obtain second X-ray. This second X-ray is very important. The main goal of the first X-ray is to make sure that the targeted lesion is removed. So the radiologist helps us on this, and so this was the area which was targeted, and the surgeon removed the right area. The purpose of the second X-ray is not only to localize where the lesion is, but also evaluate the margins. So in this case, the lesion is here. Here is the previous biopsy clip. And then the lesion extends here. Medial and lateral margins are negative. Here, anterior and posterior margins are okay. If we think that there is some fibrous tissue extending to this posterior margin, we may palpate that area, and if grossly we feel it is suspicious, we may do we can make a frozen section of this. So again, gross evaluation of individual slices is extremely important. Also, taking the right sections for histology is very important. This is a small segmental resection that we can maybe put the whole thing in. Again, how many sections that we are going to put, we make a decision based on the specimen X-ray and the density of the breast. If this is clearly adipose tissue and these are the areas of abnormality, we may not like to put the entire lesion. We can just put the representative areas of the abnormality, including the margin, but not a margin like this, clearly negative on gross evaluation. It's clearly fatty tissue. We may not put this extra section. After we take our sections, we always keep our specimens in the same orientation, and this is where inking different colors comes very handy, because even if some of the slices are misoriented, or if somebody takes this slice and puts it here, based on ink, still you will be able to identify which margin is which. So if you need to put additional sections, you can put very nicely. But we try to keep our slices in order even after we take our initial sections. During all these specimen X-ray, specimen handling is very important. There are some radiology devices to X-ray the specimen. They use this pressure, and since the majority of breast tissues is very fatty, when you put a pressure on it, you reduce your margins. So this is called pancake effect, because you are pressuring the fat against the tumor. So you have to be gentle when you are evaluating your specimens. So tumor tissue firmer than parenchyma, and fatty tissue is more susceptible to compression. So compression devices, I would caution you. Sometimes it's difficult to use. And this pancake phenomenon is pretty well known, and it affects both mean height and mean volume of the tissue. This is the surgeon's measurement before it is sent to pathology, and as you can see, there's a significant decrease, up to 50% decrease in the height of the specimen and the mean volume of the specimen. So it's really, we have to be careful. So in summary, in terms of evaluation, there is no single best method. I cannot say that like X-ray all your specimens, do this for all specimens. You really need to evaluate each specimen and then make a judgment. So each specimen should be evaluated with the knowledge of patient's clinical and imaging findings. Section and margins should be determined based on gross appearance and imaging findings. So this is a major take-home message from my talk. There are some novel techniques like intraoperative ultrasound evaluation, optical technologies. They are all nice, but nothing in clinical use right now. So our gross inspection is the most important method. In terms of defining positive or negative margin, we have a definition for positive margin, which is transected ductal carcinoma in situ or invasive carcinoma at end margin. There is no controversy about that. Everybody, surgeons, pathologists, radiologists, radiation therapists, everybody agrees on that. However, there is no agreement in the definition of negative margin. So here is a ductal carcinoma in situ, here is the ink, and then you have this fragmented tissue. So is this tissue part of this? So this was the true margin and this was separated. You know, these are all daily concerns, and every single slide you struggle with this. And I don't have a definitive answer for you. I mean, if somebody comes and says, well, no, this is the true margin, and you say, no, this is the true margin. My best advice to you is, if you use your specimen X-ray, you can look at that specimen X-ray and make a judgment between this dense stroma versus adipose tissue. So in your section, you feel that there is a fibrous tissue here and then there's a significant amount of fat, then on this specimen here, I will say that is not a true margin, but this is a true margin. So I use specimen X-ray and that gross evaluation, and for every single slide we try to make correlation. So that is very helpful. But other than that, again, it is going to be a judgment call, and some of us are very strict, and then whenever we see a drop of ink, they say, which is the margin, and then the others will say, no, gross ink was really far away, and this is fibrous tissue, so the margin is actually here. Again, emphasizing that there is a subjectivity in evaluation of these cases. And the ink can go inside the tissue. Here is a case that you have a large area of adipose tissue, but again, it got separated during the tissue processing. So you have to make correlation with your X-ray to make sure that is your margin here or the margin is over here. If you have a lymphovascular invasion at margin, you have a lobular neoplasia or a typical duct hyperplasia at margin, it is not called positive margin. So these are not positive margin. And here's a lymphovascular invasion, and sometimes you can do markers for endothelium to confirm that it is not DCIS, because in my opinion, DCIS versus lymphovascular invasion sometimes can be difficult, so we use immunohistochemistry for that. However, the definition of free margin is very difficult. And a lot of people now, they do not like to have the free margin designation in the report. Instead, they would like to say invasive carcinoma or ductal carcinoma in situ, extending to, we give the measurement of the distance between DCIS or the ink margin. So here we would measure this DCIS from this ink margin here, and then we would give the distance. In this case, we have a high-grade invasive carcinoma here, and then here is our ink margin. And towards the ink margin, usually the tumor clusters have some cautery artifact, and they are difficult to evaluate. Is it really positive or not? In these cases, what I usually do is look at them in a low magnification and see if this cluster that we think with the cautery artifact, both cytologically and architecturally, is similar to adjacent invasive carcinoma. If the answer is yes, in this case I think it is, then I will say like focus of tumor with cautery artifact is almost touching the ink margin. So this would be an extremely close margin. And when we look at the definitions of negative margins among surgeons, among radiation therapists, again, there is no agreement. That is the reason a lot of the times when we decide to make a decision to excise or not to excise, a multidisciplinary team needs to be involved. And usually the more specialized surgeon, so if a surgeon is a breast surgeon predominantly, they accept smaller margins compared to general surgeons who do maybe a breast case once a month. So the definition of negative margin in this survey among surgeons varied from 10 millimeters to no tumor on ink, like up to 11% of them accepted that as a free margin. Similarly, radiation oncologists, when they were asked to define negative margin, half of them said no tumor cells seen on ink. And 4% said, 4.9% said it has to be more than 10 millimeters, and there also remaining said like 5 millimeters, 1 millimeter, 3 millimeters. So there is no agreement in the literature. And when you look at the different trials, different groups define it differently. NSABP trials, always the definition is no tumor cell on ink. So even if it is a 0.01 millimeter from ink margin, they would feel comfortable. But again, I would like to emphasize that our main concern is not if there is tumor at the margin or not, how much tumor, what is the chance of extensive residual tumor in the remaining breast is more prudent question to ask. And there was a very big emphasis on this among breast surgeons. So the joint surgical oncology and radiation oncology groups had a meeting to have a consensus on margins of invasive breast carcinoma. And they evaluated more than 30 studies, and they screened many abstracts, including close to 30,000 patients. So their consensus statement is that, and then they are hoping that in the United States now this is going to be the new definition of margin, and the new definition that they are using now, that a positive margin is defined as an ink on invasive carcinoma. But if it is not right on the ink, no matter what the distance is, it's going to be called negative margin. We know that the distribution of tumor in the breast is different for different type of histology. So if there is on your slide extensive DCIS, then the patient may have a higher chance to have residual tumor in the remaining breast. If you look at all types of DCIS, 50% of the tumors can have residual disease with 1 millimeter clearance. And this is less for invasive carcinoma. But even for DCIS, different types of DCIS have a different rates. High-grade solid comedo DCIS usually tends to be a unifocal lesion. Microcapillary DCIS tends to have more gap lesions like this. So you may have microcapillary DCIS and you have a negative margin 2-3 millimeters, but the rest of the ductal system may have skip lesions, so you still have DCIS. So it's very important to evaluate the post-segmental resection mammograms. A lot of the times, radiologists look at the post-segmental resection mammogram and say, even though histopathology says the margins are negative, but there is residual microcalcifications. On those cases, even with the negative margin, patients may receive a re-excision. So we believe that tumor biology is very important, and because of that, individual patients should be evaluated differently, and we should not really discuss the one number being the one number being the correct number to define negative margin for all patients. For certain tumors, more than a couple millimeters might be required, and for other tumors, tumor at E might be an adequate margin. And then when we look at the tumor biology with a local recurrence risk, we know that HER2 positive tumors, they have a higher local recurrence rate compared to others. Similarly, basal cell carcinoma, higher recurrence rate. And there are also clinical factors within even the same margin width. Young patients have higher local recurrence rate compared to postmenopausal patients. The extensive component and margin status are important, but the other factors also play a significant role. So when we are trying to make a re-excision decision, margin status is important, but it is not the single factor. Other factors such as tumor biology and what type of treatment the patient is going to receive, especially now with the different types of radiation oncology methodologies, it's really a multidisciplinary decision to make the statement if the patient needs additional margin or not. So margin evaluation is important. Patients with truly positive margins should have additional surgical therapy, but there is no consensus on the definition, and the margin width is not the only factor influencing the risk of local recurrence. There's a significant interplay of patient, tumor, and treatment factors. So the multidisciplinary team is very important. Who needs additional surgery? Thank you very much for your attention. Dr. Shah.
I have a problem always with the anterior or air margin. Since that margin is supposed to be not a margin that you have to go back. How wide do you think here?
Well, it really depends on how you define anterior margin. So if it is you're meaning the skin margin?
Right.
Well, skin margin is a margin. So you have a skin on it.
Anterior, the air margin. Not superior, nor inferior, nor lateral, nor medial.
Are we talking about segmental resection, or are we talking about mastectomy?
Segment.
Okay, I don't understand what the air margin is, but we could talk about that. Please. Yes, there's a question in the back.
Okay, thank you very much for your illustrated presentation. I wanted to ask if we are going to adapt the definition of positive margin as strictly invasive carcinoma or malignancy on ink.
Correct.
Is there any importance again to measure every time the margin, the free margin?
Yes, definitely. When we give our pathology reports, we say invasive carcinoma, it is 1 millimeter, 2 millimeter, 3 millimeter away from superficial.
They are all considered negative.
Correct. But it is important to report it if it's supposed to say that the margin is free, because we don't know if it's a 1 millimeter, 5 millimeter, or 10 millimeter away.
So my second question, the study that was comparing between shaving and perpendicular sections. I noticed that in shaving specimens, the percentage of positive margin was much higher.
Correct.
Was this a false positive or it's true positive?
Well, that's the thing. It was positive, but in terms of, of course, these are all retrospective evaluations, so it's very difficult how it was evaluated and what site was evaluated for permanent section. So we don't know those things, but the whole purpose of the study to show that even though the margin was called positive, you call it false positive or what, but when they did the re-excision, there was no residual tumor. So we don't know. I mean, it could be tumor dissected right at that point, and there is nothing left. So what I'm trying to say is that even though there is a difference in terms of margin positivity rate in the different methods, when we do re-excision, finding tumor, there is no difference. So our main concern is finding additional foci of tumor in the excision, and there is no difference on that.
Okay, thank you.
Okay, shukran.
Okay, Dr. Halal.
I have a comment regarding the superficial margin. Well, breast cancer is not the disease of the skin, so we clinically and radiologically, we are pretty sure that this